So what is the infection of the kidney? Pyelonephritis. So what are the presenting features of pyelonephritis?
Fever, chills, rigors.
Sorry?
Increase in temperature with rigors.
Yeah, fever with chills and rigor. Very good. Fever with chills and rigor. And what? This is a symptom. What is the sign? Rat positive. What is rat positive? Fever with chills is a symptom. Sign is?
Bloomberg.
No.
Renal angle tenderness.
Very good. So the renal angle tenderness. Where is the renal angle? Renal angle tenderness is positive. Very good. But where is that renal angle exactly?
Angle between 12th rib and the lateral border of rectal spine.
Excellent. So this is the ribs. Suppose these are the ribs. This is the 12th rib. We have the erector spinae muscle here. So the angle between these two things in the here it will be there in the back. Okay, between the 12th rib and the erector spinae muscle. This is the renal angle. Okay, important. Just they may ask you in a spotter also. What is this? Okay, it is between the 12th rib and the erector spinae muscle. In between that there is a renal angle. So whenever you press there, you punch there, renal punch it is known as. You punch there or you press there, there is tenderness. Then it is known as renal angle tenderness. Okay, renal angle tenderness is positive in pyelonephritis. 1. Patient will present with fever and chills. 2. What is the investigation here? How will you confirm these things?
USG.
USG will show bulky kidneys. Remember, USG will show bulky kidneys with parenchymal, altered parenchymal ecostructure. That is the only thing which will show in an ultrasound. Then you do a CT. CT scan will show pyelonephritis. So what is the treatment here? Treatment. This is all you know, just I am revising.
Antibiotics.
Yeah, give antibiotics, oral or IV, intravenous or oral, simple oral.
IV.
IV.
Yeah, see, two types of infections. One is simple, one is complicated. If it is upper tract is involved, that is kidney is involved. Upper tract is kidney and ureter. Lower tract is bladder. If upper tract is involved, then you have to give IV antibiotics. If lower tract is involved, then oral antibiotics are sufficient. Point number 1. Point number 2, IV antibiotics for how many days?
5 days. 14 days.
14 days. That is the course prescribed. 14 days. This is an MCQ. How many days antibiotics? 14 days for upper tract infections. For lower tract, it is oral antibiotics for 7 days. Okay. So just remember these two, oral IV. When 14, when 7. What is upper tract? What is lower tract? Okay. Upper tract infection is known as complicated UTI, complicated urinary tract infection. Lower tract is uncomplicated or simple urinary tract infection.
Sir, exam point of view, what is the investigation of choice for pyelonephritis?
Actually, they won't ask for ultrasound or CT because there is no specific investigation for this one. There is like gold standard is not there.
Okay.
Okay. So they'll never ask pyelonephritis. Like they'll give a collective options only: ultrasound, CT, urine culture. These three will be useful. Okay.
Okay, sir. Thank you.
So drug of choice can be?
Which one?
Drug of choice can be?
Third generation cephalosporin. IV third generation cephalosporin. Okay. And two specific types of pyelonephritis: EPN and XZP. What are these two things?
Emphysematous pyelonephritis and xanthanogranulomatous pyelonephritis.
Yeah, very good.
Sorry, could you please repeat this last slide for me?
Yeah. This is emphysematous pyelonephritis. Emphysematous pyelonephritis is nothing but presence of gas in the kidney. XGP is xanthogranulomatous pyelonephritis. Xanthogranulomatous pyelonephritis. Presence of xanthomas. Xanthoma is lipid-laden macrophages. Presence of xanthomas in the kidney. It is xanthogranulomatous pyelonephritis. Clear?
Yes.
Yeah. See here. What is this?
Gas.
Gas-filled kidney.
Gas.
Yeah, gas shadow. The normal kidney will be looking like this. Normal renal shadow. It is replaced by gas. Okay. This is an image-based question. And here, what is this? This is a CT. Here also, the kidney is replaced by gas. Gas-forming organisms are there. So it is most commonly seen in diabetes, urinary tract obstruction. Again, in females, bacteria. The most common is E. coli. The clinical features triad of fever, flank pain, and vomiting will be there. Okay, fever, flank pain, and vomiting will be there. Here, for yellow is not visible. So see, the diagnosis: CT scan is more sensitive than USG in detecting the presence of gas in the renal parenchyma. Okay, ultrasound is less sensitive for gas in the parenchyma. CT is more useful. Okay, EPN, diabetes, urinary tract obstruction. It is more common in females, and bacteria. E. coli is the most common organism. What is the treatment of choice? You have to give fluids, you have to control sugar, give antibiotics, do a nephrectomy. Before that, what is this PCN? PCN.
Percutaneous nephrectomy.
Percutaneous
Nephrectomy.
nephrostomy. It is percutaneous
Nephrectomy.
nephrostomy. See, there is gas here. Put a tube inside. Just put a hole, put a tube inside so that the gas will drain outside. So this is nothing but it is percutaneous nephrostomy. Ostomy is making an opening in the kidney. Nephrostomy. Okay. And even if it is not subsiding, then you have to go for nephrectomy. Clear? Very important. Clear? Yes? No?
Yes.
Yeah.
So the first option will be PCN, sir. If the
Sorry?
question is asked, that's what we should choose. That's the option we have to choose. So, no. Talking about the management, when
Yeah.
options are given, we have to first go for PCN and not nephrectomy, right?
No. Let's see. They will not give. Everything is an option. They will not give such type of question like treatment of choice for EPN like that. The question will not be there. Okay. So
Oh,
these
okay,
are the
sir.
treatment options for kidney for EPN.
Okay, sir.
Okay. There is no definitive treatment. Okay.
Okay, sir.
So
Just
it is
want to
like,
know the
yeah,
most
you'll give IV
appropriate answer
antibiotics.
to
First, you'll give
choose.
IV antibiotics. If it's settling, it's okay. Otherwise, you'll go for PCN. If it's settling, it's okay. Otherwise, you will go for nephrectomy. It is stepwise. Okay. If
Okay.
such questions come, then it is ambiguous. The question is not clear. Okay. Yeah. So this is XGP. And XGP, I want you to have only 3 points. 1, 2, 3. What is this looking like?
Polar bear.
Polar bear.
This is polar bear. This one.
Bear paw appearance.
Bear paw appearance. Yeah. It is bear paw appearance. 1. So it has lipid-laden macrophages. Lipid-laden macrophages. That is xanthogranulomatous pyelonephritis. Xanthogranuloma means macrophages are laid with lipid. Okay. They are lipid-laden macrophages. The appearance is bear paw appearance. Second thing. And organism, most common organism is
Protease.
very good. EPN. For EPN.
E. coli.
E. coli. So E for E. EPN, E. coli. XGP. XGP, Proteus. Proteus vulgaris. Okay. And here, CT scan is the investigation of choice for XGP, and nephrectomy is the treatment option. For the person who asked EPN, there are multiple treatment options, but XGP only nephrectomy because it's a chronic granulomatous infection. There is no, the kidney is not functioning. So you have to take it out. You have to remove the entire kidney. That is the option, nephrectomy. And it is also impossible to differentiate between RCC and XGP. So you have to remove the kidney. You have to do a nephrectomy. Clear?
Yes, sir.
Okay. So remember 3 points: bare appearance, proteus vulgaris, and nephrectomy is the treatment of choice. Investigation of choice is CT scan. So what is this?
TB. Gastro-urinary TB. Genito-urinary tuberculosis.
Yeah. Genito-urinary TB, tuberculosis. See here, this is the classic picture. It was given around in some 1900s, where TB was rampant in India. At that time, this description was given. Multiple types. TB can be affecting the kidney in multiple types. Out of this, one is the most important you have to remember is cement and putty. Cement kidney and putty kidney. What are these two things? Cement kidney and putty kidney. Just think why we will call it as cement. What is the reason?
Used in construction. It's very strong.
Sorry?
Calcified
Construction. So
Very good. Calcification.
Calcified.
Yeah, it is calcified. The kidney is calcified. It is fibrosed. The kidney is fibrosed, destructed by TB, and it is calcified. So it is known as cement or putty kidney. So it's common in males, 20 to 40 years age group, mycobacterium species. This all in microbiology. Sorry. And hematogenous. It always spreads from hematogenous. From the lung, it will spread to the kidney through blood. Hematogenous. In the whole of the GI tract, kidney and prostate is the primary site of infection. Rest organs are involved by ascent or descent. Okay, kidney is involved first, then other organs are involved. Prostate is involved first, then other organs are involved. And see here, generally testis is not involved. Why? Guess. Just guess. Some reason. Some reason might be there, right? Testis TB is still now not seen. We have seen other organs. Vas TB is there. Vas deferens TB. Prostate TB is there. Seminal vesicle TB is there. Bladder TB is there. Kidney TB is there. But testis TB is not there. Why?
is it because of any endothelial barrier?
Because of
Any endothelial barrier?
endothelial barrier. Okay. Very near. Yeah. It has a tough layer around it. The tunica. Okay. Tunica, all other structures have a layer, but the peculiarity of this tunica is it has rich blood supply. Okay. So whenever any organism is lodged there, it will not enter into the testis. It acts as a tough barrier. Because of this barrier, testes are not involved. Okay. And see what happens in renal TB is suppose this is the kidney, this is the PCS. So a granuloma will form here. A granuloma will form here. They will enlarge to form an abscess. Initially, there will be a granuloma. They will be enlarged to form an abscess, and they will be bursting into the PCS. Okay. First, a granuloma, abscess, burst into the PCS. Vesical irritability is the earliest clinical. Because of this burst, patient will have vesical irritability. So this is about the GUTB. And then what are the various complications of GUTB? What is this? Anybody has seen this before? Used this before?
Thimble bladder.
Yeah, it is a thimble. What is, just remember for life. Okay, this thimble bladder is very, very, very important. Just see here. Usually tailors, because not to injure their fingers, they use this thimble, small thimble. The capacity will be only for milliliters. So the bladder will turn into a small thimble. Because of extensive fibrosis, the patient's bladder will form into a small thimble. This will be the patient's bladder. If this is the bladder, patient's bladder, what will be the symptom?
Frequent urination.
Excellent. Because there is small bladder, the patient cannot hold urine. He has frequency. So a young male patient comes to us with frequency. You have to think of GUTB. Clear? That is the question they asked in recent NEET exam. A 24-year-old male patient came to the urology OPD with history of frequency. Multiple urine examinations were done, multiple cultures were done, were negative. What may be the probability? Malignancy, GUTB, stricture. These are the three options given. So what is the option?
GUT.
Yeah,
GUTB.
GUTB. Very good. So earliest symptom is frequency, and what are the other features is depends upon the organ. Fever with chills, fever with evening rise of temperature. These are all general symptoms of tuberculosis will be there. Chronic cystitis will be there, that is not responding to adequate treatment. The epididymis will be non-tender, it will be enlarged. The chronic draining scrotal sinus will be there. Okay, sinus formation, fistula formation, induration, all these features of tuberculosis. Okay. So how to diagnose it? How to diagnose GUTB? Can anybody tell me? Think and tell.
USG.
Urine routine.
Before that, yeah, urine routine. Urine routine. Okay. What will be there in urine routine?
Growth, maybe culture.
Pus would be present.
Collection.
Cloudy liver.
Yeah, very good. So in urine routine, there will be pus cells. Pus cells will be there in urine routine. But the peculiarity of this TB is urine culture will be sterile, because this is a TB organism. Okay, other organisms will not grow here. So urine routine will be, pus cells will be present. Urine culture will be sterile. So this is known as
Sterile pyuria.
sterile pyuria. Very good. So sterile pyuria is seen in TB. It is seen in other conditions as stone and malignancy, but remember, sterile pyuria is seen in TB. And what is the stain for TB? What is the D stain? Microbiology. Starts with Z.
Seeds also.
Gill Nelson staining. So, investigation C. First of all, the urine pyuria will be there. It will be sterile and ordinary culture. First morning sample should be done. First morning sample. Because overnight, the bacteria are concentrated in the sample. So, the early morning first sample, it will have the abundance of bacteria. So, first morning sample is preferred. And plain X-ray, there will be calcification, cement kidney or putty kidney. IVP, the earliest sign, this is the earliest sign is moth-eaten calyx. I'll show you the moth-eaten calyx. This is the moth-eaten calyx, moth-eaten appearance. Moth is a small insect. If it eats the same way, it will look like moth-eaten appearance. Okay. And there will be ureteric stricture. There will be bladder will be shrunken. There will be what bladder? Simple bladder. Okay. And in extensive cases, there will be autonephrectomy. That is self-destruction of the kidney. Autonephrectomy will be there. Absence of function of kidney due to complete ureteral extrusion and destruction. There will be autonephrectomy. So what is this investigation? This investigation.
Intravenous pyelogram.
No, only that investigation.
Plain X-ray.
Plain X-ray.
KUB.
Yeah, plain X-ray KUB, kidney ureter bladder. Sorry, plain.
So I think you're using the highlighter to write. That's
Sorry?
why the letters aren't very clearly visible.
Okay, so
I think you have to choose the pen option.
highlighter. Yeah, it is clear now, right? Okay, plain X-ray. So the plain X-ray, this is the plain X-ray KUB. What is an IVP, intravenous spyelogram? Intravenous spyelogram. Think and tell. IV, we are giving something through IV. We are giving a drug through IV, intravenous. Okay. Once we give the drug through intravenously, what will happen? It will go into the kidney and get excreted from the bladder. So you take a serial X-rays. Serial X-rays after giving contrast, that is IVP. Okay. So this is 0 minute. This is 5 minute, 10 minute, 15 minutes. So if they put this type of image, then it is known as an intravenous spyelogram. It is a serial images. And this is a thimble bladder. See the thimble bladder? Thimble bladder here. Small bladder. And here it is a moth-eaten appearance. What is the importance of this moth-eaten appearance? I told you. Importance of this moth. Sorry.
Earliest symptom.
Yeah, earliest sign. Sorry, it is not symptom. It is a sign. Earliest sign of GUTB. And you do a cystoscopy. Once you go into the bladder and see, there will be this type of image. Golf hole orifice. Golf hole. See, the normal orifice will be like this. But because of extensive fibrosis, the orifice will be like golf hole. See these images. Never forget golf hole orifice. Thimble bladder, moth-eaten appearance, golf hole orifice. These three, one is a must thing. So remember, thimble bladder is seen in GUTB, golf hole orifice is seen in DUTB, moth-eaten appearance is the
Earliest sign of GUTB.
earliest sign of GUTB. And investigation, CECT is the investigation of choice. CECT. It is not plain CT. What is CECT?
Contrast
Contrast enhanced.
Yeah, contrast enhanced CECT, contrast enhanced CT scan. This is the investigation of choice for GUTB. Okay, and MRI, there will be watermelon skin sign, prostate. If you see the prostate, it will be dark here, light here, dark here, light here, like a watermelon, cut watermelon, skin over a watermelon. So MRI sign is watermelon skin sign. Where do you see bear paw sign?
XPN.
Xanthanulogrammatomas.
Very good. So it's, remember, watermelon skin sign is seen in prostate
TB.
Yeah, prostate TB. And treatment. So treatment part. If a patient is diagnosed with GUTB, never go immediately for surgery. Why? If you go immediately for surgery, what will happen?
Will there be recurrence?
Sorry?
Will there be recurrence?
Recurrence. Okay. Any other better thing before recurrence?
Infection.
Bacilli will be tubercle bacilli will be spread all over the area.
Yeah. So once you have to control the infection in TB, you have to control it. Otherwise, there will be sinus formation. If you put a hole, it will not heal. Okay. If you make an incision on the abdomen, it will not heal only. So you have to give
Antibiotics.
antitubercular treatment. Yeah. What are the various drugs? Antitubercular therapy.
Isoniazid, ethambutol,
Pyrazinamide,
Streptomycin.
isoniazid.
Very good. Okay. So HRZES, you know about that. HRZES. Okay. So once you after a patient is diagnosed with GUTB, you give ATT for 3 to 6 weeks and then do surgery. So what are the indications for surgery? This is also very important. Indications for surgery in genitourinary TB. Indications for surgery in genitourinary TB. Medical management is enough most of the times, but indication is associated malignancy is there. MIB. I remember it like this. MIB. MIB. Associated malignancy is there. Associated infection is there. Non-functioning kidney with infection or BP. Blood pressure is more. There are the 3 indications. Okay, non-functioning kidney with hypertension, non-functioning kidney with totally destroyed parenchyma or delayed function, that is infection, or associated malignancy. These are the 3 conditions where there are 3 times where we have to go for surgery. Okay, clear? Just remember this: malignancy, infection, hypertension, BP. Clear? Yes, no?
Yes, sir.
Okay.